So thanks for letting me present today on non-pharmacological approaches, again, to behavioral and cognitive health. And as Dr. Ross said, primarily we're talking about in the population with dementia. Next slide, please. So the objectives are to discuss some of these interventions. And I also wanted to just bring attention to a recent research review article that shared, which of these interventions have the strongest evidence to support controlling behavioral issues, and then just talk about the foundation for the value of training staff and for considering creating a supportive environment. Next slide. So what are some of these behavioral issues? We see them there listed on the left. These are often the ones that are assessed and measured in research, and again are a challenge in many facilities. So looking at how to control these has been the focus of attention. And current research and data suggests that 20% of those initially without symptoms will experience some symptoms within 2 years of their diagnosis, and 50 to 80% of these with clinical symptoms remain agitated for several months, as well as at least 50% of those persons with dementia that present with some of these behavioral issues. It'll be a recurring challenge on a monthly basis. And as we learned last week, medications really only provide modest symptom control, and there's concerns for adverse side effects associated with the medications. So again, as I indicated, so I found a recent or fairly recent article in 2017, which was actually, I thought it was caught my eye because it was a systematic review of multiple systematic reviews of non-pharmacological interventions. So I thought, well, maybe this really narrows it down. Most of these research articles were based on patients that were 60 years old or 60 years old and older. And again, they used a fairly strong methodological approach to review some of the data. So I'll share those in the upcoming slides. Next slide. So with regards to sensory stimulation, some of those, we're very familiar with. Aromatherapy, oftentimes in the research, they use lavender or melissa oil or even lemon balm. And there was a variety of delivery methods, from vaporizing to just massaging it into the hands. And there's really fairly low quality evidence to support recommendations for behavioral, interventions, but it is widely practiced. So I wanted to include that there. Now, massage therapy, again, this kind of goes along with sometimes, again, the aromatherapy, but this was reviewing studies that utilized massage to the head, shoulders, and even the hands. And it was more likely to be employed, especially during those times. Maybe there was an agitation going on, and typically was delivered in about 10 to 15 minutes. They did show in this 2009 study that there was a significant decrease in wandering, both verbal and physical agitation, as well as resistance to care. And then shiatsu, in comparison to acupressure, shiatsu is more of a complementary medicine that was developed in Japan, which includes gentle manipulations, especially stretches and pressures to the fingers, elbows, knees, and even feet, versus acupressure, which was more traditional Chinese medicine. Similar, but the pressure is longer and is applied to more specific meridian points in order to sort of balance energy fields. It was kind of shown in this study by Lin in 2009 that the acupressure was actually more effective in reducing agitation and aggression, as well as physically non-aggressive behavior. And in the next slide, they actually show within this study that they did, that was a 22-week study, that there was a delivery in comparison of acupressure along with Montessori-based activities to decrease agitation. And so they really wanted to try and compare what was the most effective methods, again, for some of these behavioral issues. So they compared acupressure with Montessori, which I'll explain more in a second, along with what they called presence. And presence was really just the attendance of a caregiver or a person to engage that person in some conversation. So most of these participants were male. This was again performed in Taiwan over 6 different facilities. and the participants were randomly assigned to 3 different groups. There was sort of a pre-test and a post-test, and during those tests, they measured agitation using the Cohen-Mansfield Agitation Inventory. They also did an ease of care inventory and an apparent affect rating scale. There was a 4-week period between some of these interventions, which included that post-test, a sort of washout period, and then a pre-test before the next intervention. The acupressure and the presence were provided, once a day for about 15 minutes. And again, across about a 4-week time span. And the acupressure, again, was applied as detailed before by a trained physician of Chinese medicine. And the Montessori activities were performed actually more over a longer period of time, about 45 minutes. And this included sensory stimulation with rhythmic music. They did some warm-ups, some stretching. They followed this with some procedural activities that included matching, calculations, sorting, abstract concept ideas. They did some cognitive memory training, and they encouraged patient discussion. And so this also included both gross and fine motor skills. And then they would finish the day with a review of the activities and then a discussion or an announcement for the next day activities. And in the next slide, we'll see kind of the results of this intervention in comparison. And both the acupressure and the Montessori methods both significantly reduced both agitation and ease of care. There wasn't a significant reduction in verbally agitated behaviors, but the apparent affect scores were more significant following the Montessori intervention. And this was considered to be likely due to more of the social interaction during this type of intervention. And we'll discuss this a little bit more later with Artie. Next slide. So some other sensory stimulation interventions, you may have practiced these or heard about them, but light therapy. It's found that light therapy has sort of an association with sort of rest, activity, or sleep-wake cycles. And these are considered to be controlled by the endogenous circadian rhythm that's generated by the suprachiasmatic nucleus. So I'll just call it the SCN of the hypothalamus. So we know with degenerative changes in the SCN, there appears to be a biological cause of circadian rhythm disturbances, especially in persons with dementia. So the evidence suggests that the circadian rhythm disturbance might be reversed by stimulation of this to light. So there was a review of 11 different trials using different sources of light therapy. And there really wasn't a significant improvement seen on the impact of sleep or behaviors or depression. And this was somewhat surprising to me because I still hear this being sort of utilized quite a bit. But I will say, in contrast to this, in a more recent study in 2017, where they did some outdoor stimulation in the sensory garden, they did find that there was a positive impact on reduction of verbal agitation and actually maximal sleep duration. So maybe there's a correlation between the light and also maybe the activity. And in these sensory gardens, they were designed to stimulate the 5 senses: sight, vision, hearing, smell, and touch. They compared this also in correlation with, or in comparison to, those activities where people were actually just kind of working with plants or doing plant-related activities. And there was actually, again, a more significant decline in some of these behaviors when actually those activities were performed outdoors versus indoors. So it might just be something to consider. And then another sensory stimulation is music therapy. And this was delivered in multiple ways, from singing to listening to performing, even rhythmic exercising or improvising. So these were shown to reduce behavioral symptoms, especially related to depression or anxiety. And also it was done in correlation or in combination with mealtime. So mealtime music was shown to improve both physical and verbal control behaviors, as well as some non-aggressive behaviors. And so just a consideration as well, we'll be talking about that even further with some dining environment considerations. So the next slide. So there's also some interventions more directed towards cognitive or emotional oriented activities. And some of these, first of all, with cognitive stimulation, we consider these were a variety of research studies that looked at pleasurable activities such as word games, puzzles, music, cooking, again, gardening, discussing past and present events. Usually these were carried out by trained personnel in small groups of about 4 to 5 people. A lot of these activities lasted for about 45 minutes and were performed or provided a couple of times a week. But many of these were identified as sort of low quality studies. But there was a small study that was more focused on individual interventions. And these addressed more executive functions and working memory. And they did find that this did provide some significant reduction in behavioral symptoms. And, I personally attribute this contrast maybe to have some relation to intensity or challenge of the cognitive stimulation. We'll talk about this later with regards to physical exercise, but if you think about it, when we're really working on more executive functions or working memory, that's a little bit higher level challenge than maybe some of more the other activities, the pleasurable activities of the games and puzzles involved with the other studies. And then reminiscence therapy. This is, as you know, discussion of past experiences and events and activities. And usually there's photographs or books or old newspapers or maybe familiar items that are used to inspire and past experiences and really facilitate individuals to share in their discussion and value their experiences. They did find that this had significant improvements with reducing depression, improving communication, and affecting mood and cognition as well. And then validation therapy. This is usually intended to give an individual an opportunity to kind of resolve unfinished conflicts by encouraging or validating their expression of feelings. And really acceptance of the reality that they're in or the personal truth of another person's experience. So this can incorporate a range of specific techniques. It can be done both in group or individual settings. In this study, there was a skilled nursing facility group where they did 30-minute sessions 4 times a week. And it was, again, a group setting. They did a very formal approach of introductions, maybe, again, conversation on a subject of interest that was identified. They did activities of recalling past events. They also did some activities with singing and poetry activity. And then they kind of wrapped it up a little bit with refreshments and goodbyes. And through this intervention, it was a study done a good time ago. There was a significant decrease in depression. But I more currently hear this validation therapy utilized more often, more in an individual situation, especially to deal with some of those immediate behavioral issues at the moment. So, and we'll talk about this as well and more of that positive physical approach that maybe we've all become a little bit more familiar with. So on the next slide, we talk a little bit more about some other interventions as well as some combination interventions. One of those being this nature walk. Just the sound of it sort of makes me calmer, but instead of just actually walking outside, what they did was they would simulate sort of a walk in this environment and maybe even have a hallway that was had large bright pictures that included nature scenes or maybe pictures of birds. They would also have audio going on that had bird songs or maybe sounds of water. And they would also include in this intervention maybe oral, pleasurable oral stimulation with foods such as bananas or puddings or sodas and things of that. And they actually found that this did decrease agitation, especially with persons that had late stage Alzheimer's disease. And so maybe just a consideration for that group and population. And then as mentioned prior, here's the hand massage and music. They combined that. They actually did show a significant decrease in agitation immediate following this intervention, as well as even 1 hour post intervention. And then I think we're familiar with kind of animal assisted therapy. I included this. They actually showed with several research studies that this may have a positive influence on decreasing the degree of agitation and improve the amount or quality of social interaction. But there was suggestion in many of these studies that there needed to be more examination or research of examining the optimal duration or maybe the frequency of sessions, or possibly even the suitable target group with this. And several of these studies used both real animals, primarily dogs, but there was also the use of some robotic animals, especially cats and even a seal. And then the dining room environment. This kind of brings back just again a combined intervention, considering a little bit the environment itself, as well as, in creating more a stimulating atmosphere from the table setting to just, again, the structure and the setup. They also train staff on education on specific things to consider with mealtime with elderly or older adults, as possibly as far as assistance that they might need, maybe encouragement with eating, and then even the use of music in the background. And overall, there was a positive effect on behaviors and also reduction in daily agitation that they saw. And I think if we have anyone with us today from the James L. West group, I know that they were doing a intervention with this. I don't know how much they were including some research or study with it, but I'd love to hear from them. But from what I recall, when they described it as well, they talked about creating that atmosphere of table presentation. I think they were doing music as well, and they were engaging their staff to eat at the same time as residents. So I'd love to hear from someone in that group, or maybe Barb might have some insight into that as well. So I think opportunities exist really to select and combine interventions which align also with the facilities environment, obviously staff availability, and maybe again what your resident needs are. And then, of course, as a physical therapist, I want to bring attention to some of the exercise and physical activity and truly what impact it has had on behavioral control. So there are many of these exercise interventions were some combined exercise program. There were 5 random control trials that looked at this and reviewed it. Oftentimes they included a combination of aerobic, strength, flexibility, and balance activities. The research trials varied from 30-minute intervention sessions all the way up to an hour, and as low as twice a week to some even programs including 7 days a week. Many of these included walking, but overall, there did not show in these trials to be a significant change in behavior from the controls, except for the group which also met with both the patient and the patient care provider. And in this trial, what they also included was some caregiver education on how to manage symptoms. So, somewhat interesting that maybe, again, thinking about how you might combine this exercise group with some additional opportunities like education. But the other thing that I noticed in these exercise trials, there really wasn't any details provided on the intensity of the exercise intervention, which appears to be garnishing more attention with positive outcomes in recent research trials. And that is shown in the next bulleted item there, the moderate to high intensity exercise. This was a group that actually did a little bit more intensive exercise. It was a longer period of time of that hour duration. It was provided 3 days a week over a 16-week period. It was a group more so with mild Alzheimer's dementia, but they did show that it both reduced behavioral issues as well as preserved cognition. So when we're thinking again, maybe about some of that early stage, this would be a good consideration and an encouragement for implementing this type of program. And then lastly, there was a group that studied and compared aerobic exercise versus cognitive. They actually did a comparison and then a combined group. So they had one that combined the exercise with the cognitive therapy, as well as doing independently. And then they also had a control group. Both the aerobic exercise group as well as the aerobic exercise and cognitive therapy group showed some cortisol levels that were reduced by 26% for agitation and even 50% for altered behaviors. Also part of this recommended interventions was they showed some improvement in addressing sundowning. And in a more recent study, she and colleagues showed that walking 30 minutes a day, 4 times a week, and it didn't necessarily have to be right before bedtime, it could be morning or afternoon, showed that there was also a good impact on controlling sundowning syndromes. So thinking about progressive walking might help with that behavioral challenge. So in the next slide, we talk about, again, thinking about integrating some of these programs and intervention into your facilities. There's some suggestions about how to sort of integrate sort of these models or theories into the value of doing some dementia-specific training programs. And really, there's some increased efforts really that we should be considering, both training staff as well as considering the environment. This person fit theory, really addresses that, for thinking about how the person must accommodate and adapt to the changing demands of the environment, but also that the environment must be modified and changed to accommodate the changing needs and preferences of the person. This goes along with the social learning theory that states that behaviors are initiated and maintained by a series of reinforcement contingencies that can be modified to alter the frequency and severity of the behavior. So thinking about this, there was some early research done in 2005, which created the STAR model from researchers Morrow Howell, which I think has also been reflected in some current training workshops as well, that really kind of, again, thinks about and considers value and that dignity and respect for the residents, training the staff, again, to be more responsive, and building those staff skills. And as I read through this research and study and the theories behind it, I think it very much is reflective in some of the positive approach to care training that is provided by Teepa Snow on her online workshops and in person, and really, again, addresses those abilities to respond rather than react to a person with dementia and their change, and abilities that's really more proactive and not harmful or offensive. We also need to appreciate that with practice, common reactions to a person with dementia can become more thoughtful responses that really improves everyone's quality of life. And that we recognize that the person with dementia is doing the best they can when faced with challenging situations. And we really need to think about changing our approach, our behavior, and our expectations for improved outcomes. And by modifying the physical and sensory environment, including lighting or sound, or even the activity that surrounds a person living with dementia, we can actually help promote function and satisfaction. So in the last slide, I just want to kind of bring attention again to some of the key points and content that we discussed today, so that we can take this into our breakout sessions. Is that, overall, I think massage and acupressure, they have good evidence to reduce agitation and ease care, and so may value in considering these within your programs. I myself really love the idea of integrating sensory gardens and even outdoor activity to address and reduce agitation and depression, and possibly even sundowning. Considering how music therapy could be valuable, again, when reducing agitation and depression. It does seem that more receptive music is important, especially for people that might have apathy. We didn't have time to discuss that today, but just a consideration there. Pet therapy can reduce agitation and even apathy and improve social interaction. And again, the discussion on intensity. And so we think that moderate to high intensity activities can help preserve cognition and reduce unwarranted behaviors. And think about how you can engage caregivers in those activities as well. And then hopefully we're all thinking about how to really prepare both our environment and our staff in training opportunities on a regular basis to just keep everybody up to date with those interventions that you have adopted, and how the evidence is really kind of supporting reduction of behavioral issues. And so I'm going to turn it over to Arti. There is some additional slides there, a couple of them with references for your review later, if you'd like to learn a little bit more about some of those intervention trials. but I think RT is going to discuss a little bit about more so Montessori approach.
Thanks so much, Kat. We're getting RT slides up, and then we'll have our discussion portion following RT's presentation.
Thank you, Dr. Camp. So today's QI portion is going to focus on Montessori intervention for individuals with dementia. Next slide, please. Okay, so we are going to learn how a facility implemented Montessori activities for individuals with dementia, look at what feedback they had, and what are the barriers that they faced. Next slide, please. Okay, so what is this Montessori intervention or Montessori approach? First and foremost, it's a non-pharmacological intervention. It is very person-centered and it is evidence-based, as you saw in Dr. Camp's presentation. These are all psychosocial interventions that is very cost-effective and very easy to deliver. So this Montessori method is a system of teaching which was developed by Maria Montessori, and it is based on principles to promote learning and independence in children. So in context of dementia care, this method has been tried and found to be moderately effective in improving certain behavioral outcomes like eating behaviors, improving residents' agitation or mood. And it is, again, as I said, it is person-centered, so it is more on designing and offering activities that take into consideration the person's interest, his or her needs, what were their past experiences, and what is their preference if they want group or individual intervention. Next slide. Okay. So this is how a facility, this is an example of a facility that implemented this intervention for their dementia care patients. So first they held educational workshops for all life enrichment staff. And then they had this 6-month in-depth study so that few of their staff could become certified practitioner in Montessori for aging and dementia. And once they had the certified practitioners who could deliver this method, they focused on creating a prepared environment within the nursing home. So few things that they did were bedrooms were marked with person's name in large print, and a large photograph of the individual that the person could recognize was put up on the door. And then visual cues were used to invite individuals to use materials like please shine your shoes, please help yourself to a drink, or things like that. And then activities, as I said, they were very person-centered, so it had to reflect the residents' culture and offer relevant hands-on experience. So for an example, a person who used to enjoy gardening, he or she could attend to an activity of watering and tending to plants. So it was more taking into consideration what the person wanted and what they could do. So this is about creating a prepared environment. And then once they implemented this, they wanted to follow up and see if that's making an improvement or not. So this is the facilities review. So they saw that observing and learning about the interests, capabilities, and needs of individuals were very challenging. So initially they found all this to be a little tough. They couldn't really capture what that individual wanted, what were the preferences and things like that. So with trial and error, with lots of surveys, by talking to the resident, their families, their dear ones, they helped identify activities that were meaningful and that could engage residents. And they felt that the activities that they implemented were unique, they were interesting, and they were strengthening residents' self-worth. So the resident felt really worth, and they were participating in all these activities. So they took great interest. Like stacking poker chips, sorting out clothespin, animal sound match, and things like that. And again, as I mentioned, these are affordable activities. They could be done with a limited budget. So it was very easy to implement and see improvement. Next slide. Okay. So definitely there were a few barriers in delivering Montessori intervention. First and foremost, to have dedicated staff, then train them. Getting them certified in Montessori practices was a little difficult. And of course, with staff turnover, it became more and more tough. And again, this is like a multidisciplinary approach. So if you do not have a good team, it cannot sustain. So lack of a large, cohesive, multidisciplinary team to lead and sustain this initiative was a big barrier. So you definitely need a dedicated team for this. And they collected feedback from residents to see if they were really enjoying this intervention. These were a couple of things that the residents mentioned. One was like staff were very cooperative and respectful towards them because these staff were addressing them on individual basis. So residents felt really happy about it. And then staff sat with them and performed activities. So they felt like a family and more engaged. And of course, it increased their self-worth, self-esteem, and also the level of engagement in participating in these activities. Next slide. Okay. And then, of course, they had little suggestions for improvements. So they sat together with the interdisciplinary team to find what more could be implemented, how could things be sustained. So they felt like some of those Montessori interventions that they were doing, those sessions were a little long, and that was kind of exhausting those residents. So they wanted to keep this Montessori intervention session limited to 1 hour. And as you would have seen in Dr. Camp's presentation, the study was where they Montessori intervention limited to 45 minutes. So I think that would be an ideal time to implement that. And then, of course, involve family members, involve their near and dear ones, caregivers if possible. And having this outdoor or physical activities can help with socialization as well as promote easy engagement, like having this gardening things or helping them with any outdoor activities that could promote more engagement had great significant improvement. Overall, when they looked at what was the satisfaction of staff, they felt like employees' job satisfaction was higher after implementation of the Montessori program. And that was because the staff who participated in the training and when they witnessed these changes in the dementia patients or patients with dementia, they reported a great degree of job satisfaction. So most of their staff were very happy that their residents or patients were showing improvement and they were actively engaging and they could see that visually. Next slide. Okay. These are some keys, do's and don'ts of Montessori approach. So do's are like having that prepared environment, encouraging them, making frequent touch points, making it very person-centered and things like that. And the don'ts are something that I would really want to stress on, like do not correct someone who's doing an activity. Let them do it, observe it, and then probably give your suggestions. When they're doing something, do not interfere. And giving wordly instructions is something that's not suggested in Montessori approach. You try to make it more visual. So adding visual cues are something that you would really want to focus on when you're creating your prepared environment. And then doing activity for them unless they're becoming frustrated and need a boost. So don't do that. And then focusing on only one right way to do an activity, like gardening. If the person wants to start with putting seeds first, then watering and things like that, that's fine. Or if they want to really just work on harvesting and things like that, then that's the right way to do too. So each person has their own way of visualizing gardening and things like other things. And then using activity materials that are childish, like playing cards which are made for children and all that. Do not try to implement that. Make it more adult specific and more person-centered. So this is a great tool, and I have linked it to what are the Montessori techniques that you could utilize for this